Hello everyone and welcome. Thank you very much for the invitation. I'm going to talk about a little bit of how to decide if you want to pick radiofrequency, pulse radiofrequency or cryoablation. Before we get to it, I want to invite everybody and your residents to come to Budapest to a comprehensive pain education program. It's pretty much like an MBA program. You come 4 times throughout the year and can learn pain management from the basics to pretty advanced level. And we have lectures, we keep in touch with you, and cadaver workshops and other workshops too. This is my disclosure slide. This is not a paid talk, but I am a speaker for Metro, Minomed, sometimes for DEROS. I am a co-founder of Pain School International. I am on the WIP Education Committee, and I'm faculty for a variety of societies. I myself trained in Budapest, spent some time in the States and then BC, and now I'm back home after 10 years. So this is the outline of the talk. We're going to review the basic concepts and differences between cryo, PRF, and RFA, and then we'll look at a couple of clinical scenarios to review how do we deal with a joint innervation, a pure sensory, a mixed nerve, or a mixed ganglion innervation. And of course, we'll touch on the evidence a bit. So what are the indications? It could be, of course, chronic pain, which I would split in 2 main groups. A musculoskeletal problem that we cannot fix, let's say a knee osteoarthritis, so we take the nerves out, we innervate it. Or we can talk about actual nerve origin pains like neuralgia and nerve entrapment, neuropathies. And of course, now it's coming up that we use these procedures also for acute pain, and for a long time we have used them for cancer pain. So radiofrequency ablation, without digging too deep, it is actually coagulating tissue, so it is going to be irreversible. It has some advantages and disadvantages, right? It will provide a complete block. It's exactly like a local anesthetic if you do a good job, which means you lose sensory and lose motor. Like it might be an advantage or might be a disadvantage. The results will last more than 6 months. It's very easy to place it, and we have lots of studies available for radiofrequency. However, it has some disadvantages. If you do radiofrequency on a myelinated nerve, it can lead to a possible neuroma formation, which means worsening pain, and therefore it is not suitable for all peripheral nerves. It's pretty common after RFA to get a neuritis. Then we go to cryoablation, which is really application of cold tissues to create a conduction block. Again, it's going to be very similar to local anesthetics. When you do cryoablation, you will denervate, you will destroy the axon and the myelin, but you do not destroy the connective tissue. So the epineurium, perineurium, and endoneurium remains intact, which means the nerve will regrow in the exact same pattern as it was before. So look at the advantages, disadvantages of cryo. It provides a complete block like local anesthetic. It will last 6 or more, a month or longer, because sometimes when the nerve grows back to a healthy environment, the pain will not come back. No, the nerve does grow back to the same exact way, which is also an advantage because you don't have to look for it. If it needs repeat freeze, you can go back to the same location. Placement is a bit more difficult than the other probes. It will not lead to neuroma formation. That is again because the perineurium, epineurium remains intact, which means you can put it on any peripheral nerves. And let's talk about pulse radiofrequency. So how does PRF work? It has a variety of mechanism of actions. It alters the synaptic transmission, it modifies gene transcription, has a neuromodulatory effect, an anti-inflammatory effect. And it also has advantages and disadvantages. I would say an advantage is that it doesn't create a motor or a sensory block. It may last up to 12 months. Very commonly it lasts, I would say, 3 to 6 weeks. It's very easy placement. There's no neuroma formation, no damage to the peripheral nerve. So therefore you can apply it to any peripheral nerve. But I would say the success rate is lower, even if you do a good job procedure-wise. So what's the general approach? It doesn't matter what you want to RF, cryo, or PRF. You need to get the diagnosis right. And the reason I'm saying this, I know it sounds obvious, but very often I would get a question like, oh, knee pain, what do you radiofrequency, or what's the target? Oh, I don't know, what is the diagnosis, right? So we need to establish a perfect diagnosis, because some don't need radiofrequency. Some need the recognition that it's a pes anseremus enthesopathy, needs a different treatment. Okay, so we do a successful diagnostic block. Key with the diagnostic block, that you want to be really, really specific. You use very little local anesthetic, meaning 0.5 to 1 cc of local anesthetic. Because your radiofrequency lesion and your cryo lesion will only be so big, which means if your local anesthetic goes everywhere, it's no longer specific. We no longer have the answer if our block, our denervation procedure, cryo RFA, will work or not. Let's talk about the knee. Also, I think it's a bit of a somewhat confusing area. So we're going to look at knee as a joint denervation, and then we'll also look at a neuralgia, which is also knee pain. Okay. So this is a procedure that I'm going to demonstrate briefly. This is denervation of the inferomedial genicular nerve. You can see the tibia. This is where the tibia shaft and epicondyle meets. Here I am putting in the introducer I'm looking for a laser pointer, all the way to the target, and then the cryo probe gets inserted. Now what you see here, so the junction of the tibia condyle and the shaft, you could see the needle coming in. You could actually see the MCL, I'm outlining it somewhat, which is under which is your target mostly. And here you can see the cryo probe touching all the way to periosteum. And if you wait a minute, you can start seeing the ice ball formation. So one thing to notice here is that the ice ball is actually pretty big, right? And this will be a benefit to cryoablation, because it will give you a big lesion. So staying with the knee, just to touch on it, you guys all know for sure the studies from Philip Peng and his group, the nerve frequency pattern. It's been a discussion where to put these lesions exactly. Should we put here? Should we put there? But really, the conclusion is the bigger, the better. If you place it more posterior, let's actually look at here. If you place it more posterior, you will get these branches. If you place it more anterior, you lose these branches but keep these ones. So one way to overcome that is to make a bigger and longer, almost like a strip lesion. A couple of pearls to succeed here. Don't use the artery so much for a guide, because the artery really can be in any position, and very often in the elderly it's not even visible. If you place the needle too anteriorly, you get the branches of the nerve to the vastus medialis, but you miss the superomedial genicular nerve. And if you place their needle too posterior, it's the other way around. So again, do multiple lesions. So how do we decide now? Do we do radiofrequency or cryo or pulsed RF? I would say if pulsed radiofrequency is immediately out, because it's a very temporary lesion, although there is one study supporting its use for knee. But it doesn't really create a lesion. You don't want to neuromodulate. These are small nerves that you can take out. So we're left with cryo and radiofrequency because we are looking for longer term results. So the things to consider: what is the lesion size? Because that leads to success or failure. If you are using, you can use radiofrequency and you can make a strip lesion. Usually, actually, for some reason, this is my preference because it's much faster. I can use a big 16 gauge needle. I can place it along the femur here at multiple locations, and I can actually place multiple probes at the same time, so it's fairly efficient. Done. The trouble is that you have to tell the patient, okay, it's going to take 2 to 3 weeks until you know how we did. Now, cryo doesn't have that. The lesion size is pretty big. Time to effect is very short because the patient will get off the table already loving you. That's perfect. But the time to perform is taking forever if you want to do really multiple lesions with the cryo. Also superomedial, superolateral, inferomedial, it's time consuming. And then finally you want to consider price. Radiofrequency is cheaper than cryoablation. And also we need to consider, of course, the available evidence. Now this is an easy summary. We have lots of randomized controlled trials for radiofrequency, but we do not have RCTs for for cryo for this indication. Let's move to peripheral nerve entrapment and neuralgias. You could target any nerves, any peripheral nerves that we recognize, we know about, we can identify, diagnose, and possibly see with ultrasound, we can target. But one thing we need to recognize is that we have much more studies available for radiofrequency and pulse radiofrequency than cryoablation. Even if I might give you a feeling with this talk that cryo is the magic bullet, it is not. We need, or maybe it is, but we need to have much more studies. So again, what is the general approach for peripheral nerve? You need to get the diagnosis right. So you need to understand the nerve innervation pattern. You identify that this would be my nerve. It's consistent with the mechanism of injury. And then you do a diagnostic block, again with very low volume local anesthetic. So let's pick one, infrapatellar saphenous neuralgia. So the infrapatellar saphenous nerve is a branch of the saphenous, right? It curves anteriorly off the saphenous nerve, innervates the skin here, and a neuralgia can really give a terrible burning pain. The patients are unable to even extend or flex their legs. This is how a nerve would look, but I'll show you another image. Remember that the ultrasound probe would be here, just parallel to the patellar tendon. And if you cryoablate, that's how your probe would look. So again, here you can see the saphenous nerve coming laterally, piercing through between the sartorius and the gracilis, and then branching, giving off the branch to the infrapatellar saphenous. And when you look at this with ultrasound, you actually can see it. So here's a case. The case is from last week. The image is from years before. So last week I had a patient, 16-year-old girl, who was a soccer player, training to be a professional soccer player, had slid in to catch the ball, had a knee injury, and after 2 weeks rest, she returned to sport full power. However, 2 months later, spontaneously developed infrapatellar saphenous neuralgia, burning pain. At the time of the visit, she comes in a wheelchair. The knee barely bends, and the skin is super hyperalgesic. When I looked at her infrapatellar saphenous nerve, this is what I saw, actually. Although this is not hers, but this is how it looks. A nerve that's upset, that's entrapped, will be always more visible than the one that's a happy nerve. So this is a swollen infrapatellar saphenous nerve. And this image is from this paper. This is a longitudinal view, just to get oriented. Oh, sorry, here. So the longitudinal view of the nerve. Here you have the femur, the tibia, and you can see this is the outline of the nerve. You can see a neuroma. So sometimes you can actually observe a big, huge neuroma, even on a small nerve like this, and then you know it is a problem. It's good for diagnostic purposes as well. So what do we do with this patient? We could do cryo radiofrequency or pulse radiofrequency. We'll consider the same things as before. Lesion size. Lesion size will be the biggest with cryoablation unless you do cooled RF. However, radiofrequency will give you a neuroma, and you definitely don't want to give a neuroma to a 16-year-old, because then the pain, as the nerve grows back, it will hit up against the scar tissue, and the pain will be much worse than it was ever before. So we can do pulse radiofrequency or cryo. A pulse radiofrequency is a harmless thing to try. Maybe it works fantastic. However, if the results are too short-term, then you can consider cryoablation. It's a big lesion. You can rehab a patient. This is, again, a 16-year-old. So even if she has an instability that leads to entrapment now, that probably will recover with time. And in this case, time to perform the procedure is the same as with radiofrequency. Okay, so in this case, again, no radiofrequency. Maybe PR pulse radiofrequency, but I would say small chance of success. But yes, for cryo. And in this case, the infrapatellar saphenous doesn't even cause a motor loss because it's a pure sensory nerve. So this is how the procedure looks. You can see the nerve with the arrow marking it, and my cryo probe leading to the nerve. And the successful freeze, in this case, which is again a different patient, led to absolutely complete pain relief. So let's look at a mixed motor nerve, a sciatic nerve. Assume that the patient has a tumor at the femur, undergoes surgery, and the sciatic nerve was encroached. So there is sciatic pain post-surgery. What do you do? Like, each of these are very different clinical scenarios. On the left, I couldn't quite find the right picture, but assume you have a cancer pain patient where motor function is not key, but time and pain relief is really important. You don't want to waste your time with pulse radiofrequency, because if it doesn't work, you took time away from that patient. You could do cryo and you could do radiofrequency, because in this case, you're not necessarily worried about the long-term neuroma formation. You want immediate, for sure, results. Cryo would be my preference because of the lesion size. or multiple needles or bipolars with radiofrequency. Also wonderful. But on the right side, if you look at this young woman, she had the tumor surgery, she's done. She wants to return back to function. There's no way you can cryo a sciatic nerve or radiofrequency because she needs to walk on that foot. So PRF is the option that's left for her. Or of course, stimulation and other projects. But sticking with this topic, PRF is the choice. Think of a different one, phantom limb pain or stump pain. Okay, are you worried about the motor function? Not necessarily. Do you need a very good pain relief? Absolutely, because they want to wear the prosthesis. So your options will be, you can do PRF, success rate low, but maybe good. Maybe you even have time to play with it. Cryo, probably good. Good for phantom limb pain, good for stump pain. Also, again, of course, after a successful diagnostic block. And can you do radiofrequency? Not really, because it will lead to a neuroma formation and the pain will get worse after like half a year after your treatment. If you look at the evidence, again, it turns out we don't have many, neither for PRF, for RF, or for cryo, only case studies, case reports, case series. This is probably the biggest one, phantom limb pain, 21 patients, 6 months follow-up. And this is a negative study, larger number, did not do any difference for phantom limb pain, the cryoneurolysis. Another important one is trigeminal neuralgia. We have lots of studies showing that gastroganglion RFA works. It has good evidence. The study by Dr. Manzano just came out recently, again proving good success of the radiofrequency. With pulse radiofrequency, we can do, we know, I don't have time to show you data, but the relief is achieved in half the amount of patients compared to the RFA, and the length of relief is also half the length. So you can do PRF. The good news is it's not a coagulative procedure, so it should be less risk. And so that's why when you look at side effects and complications, PRF is better, but RFA is more reliably working. And finally, let's just compare the three of them, RFA, cryo, and PRF. On myelinated nerves, RFA will be an irreversible lesion, whereas cryo and PRF will be reversible. Both RFA and cryo will give a motor loss, whereas PRF won't. And similarly, sensory loss will come with RFA and cryo, but not with PRF. Now, when you worry about neuroma formation, it does not affect cryo and PRF. Placement is, I gotta say, hardest with cryo because it's the biggest probe. But how sure can you be in the procedure? With RFA, you're pretty sure, but the needles are not very big unless you use the cooled RF or bigger lesion. Sometimes I do use 16 gauge needles. Cryo, pretty certain, big lesion, you saw it at the video I showed you. PRF, there is no lesion. And similarly, with the pain relief, the bigger the lesion, the more likely that you incorporate your target. And then how long it lasts, probably RFA lasts the longer because the nerve do grow back and with cryo. And then with PRF, we have data showing 3 to 52 weeks results. Okay, so I'm not going to repeat this particularly because I'm out of time. Thank you very much for your attention and I'm ready for questions.